Good morning, good morning. On this beautiful Tuesday evening, for those who do not know, we always say good morning in Longrich, no matter the time of the day. My name is Pulane and Refilwe, your global product specialist. Welcome to the Health Hub. Okay, I can see that I'm still alone, so I am going to advise. I'm going to share the link with our respective groups, and hopefully we will get our leaders to join us. Ne? In this very important training, which is on breast cancer. Right. Good morning, leader. Hi, how are you? Where are you from? Let's see. Okay, let's see. Let us start the training. Good morning, great leaders. Okay, the numbers are picking up. Good morning, great leaders. Can we kindly please share the training with our respective groups? We will be training, or should I say, we will be trained on breast cancer. Let's see. So I'm going to give it a few minutes that we share this link. I'll give it about 2 minutes. It's 19:03. So 19:05, we will make a headway. And what is this? The Health Hub is live on a Tuesday. Unfortunately, yesterday we had an unforeseen incident. No electricity. Hey. Okay, let's kindly share this training with our respective partners, with our team. I'm also I'm also sharing I'm also sharing with my respective groups, and I'm also sharing with my clients as well, as this is important. Um, okay, we now have about a minute to go. Okay, now we're just waiting on PS Refilwe. Good morning, great leaders. Welcome to the Health Hub uh, on this beautiful Tuesday evening. We normally do trainings on Mondays, but yes, unfortunately, we roll with the punches. We had to postpone the training to today, or should I say tonight? Let's just see what's this. Uh, yeah, I'm just sharing with the respective groups and my clients as well. Training on breast cancer. Please share, say hello. Who is here? Now, leaders, do you know that when you join the training, I need to see who's here. Say hello. Where you from? Let's see. Hey guys, me, I don't like to be a, what do you call it? This is not a monologue. I like to know who's here, who's with us, where you from, so that as well we raise awareness that Long is actually a global platform, like we always advocate. So I'm just waiting for our PS. I'm not sure on her side. Um, God, she says she has a problem with network. Okay. Oh, she says she's coming. Okay, we are waiting, PS Refile. Good morning, Regina. So the topic of today, welcome Leader Riri. Welcome Leader Riri, Leader Bolande. Leader Bolande, I know you are from Nigeria. Leader Riri, I'm not sure where you are from. Welcome, great leader. Please invite. This is a topic that can all benefit from. Okay. So invite. We're just waiting for our there she is. Ladies and gentlemen, you know most I'm hyper. I'm that girl, that PS who's so hyper. Oh, look now. Look now what I did to my ring light. Okay. That was not supposed to happen, okay? So apologies. Let's see, where's our PS? Where's our PS Refilwe? I man, Refilwe. Let me just see. Device is not connected. Okay, she didn't connect. Let me just send her a message. Her device is not connected, so I cannot add her. I cannot add you. Your device is not connected. We did do a quality sound check. Hey, Bolande, life happened. My ring light is in tatters. So, okay, you want to fix it live in the show. Okay, let me fix it for you, my darling. You know, I roll with the punches most. Me, I don't, we don't get nervous. Ne? We roll with the punches. We make things work. Is that better? Okay. Hey man, there's shadows everywhere. As long as it's light, there'll be a shade. Oh man. Okay. Here is our PS Refiller. Are we ready, leaders? Are we ready? I hope you have mobilized your teams, you have mobilized your clients, because PS Refiller is a specialist of all sorts. She is a radiographer, she is a mammographer, she is, yes, a long stockist, and she's also a long range product specialist. Yes, Yabangena. So let us welcome PS Refiller with open arms. Hey!
Hi, leaders.
I didn't marry, you know, I'm hyped, so I'm sorry. I'm so excited.
Good morning. Good morning.
Good morning. Good morning, Ospifi. No, network again.
Good morning.
Your network.
Good morning.
No, your network is not working, my darling.
Hope.
What happened?
Uh,
Your network.
how am I right now?
Now you're
Everything is
okay.
connected.
What happened? Now you're
sharp.
Now you're okay. I don't know what happened the first 2 minutes, 3 minutes.
Let's pray that everything will be fine. Let's cross fingers.
Well, let's cross everything that's possible. Like even your eyes, cross them. You know, you know, do the cross eye, cross everything. But you need to pay attention. Yes, like because wow,
Yeah,
everything was working.
Let's cross everything.
Yes, let's cross everything that needs to be crossed, that can be crossed. So, TPS and Refiller, welcome. This is your second time on the show. Thank you so much for availing yourself to us. Also, Refiller, we know you are very busy. Hello, Wankupa, can you hear me?
Thank you very much, leadership Pulane, PS Pulane. Thank you very much. Yes, I can hear you. You are good.
Oh, okay. Thank God. Yeah, thank God for that too. You are also good. Okay, PS Refiller. So today we are training again on breast cancer, your specialty.
No, you are very good. Yes.
Now, PS Refiller, please just give us your background. What do you do? Just fill up for a couple of minutes. Give us your background so that leaders
Yeah,
can actually
today we
understand
will.
where you're from.
Okay, my name is Refilwe, surname Sekwaila. I am a radiographer, mammographer, also a product specialist in Longrich, and also a Longrich stockist of Pretoria some donkey years ago. And then mammography, I did it in Cape Town. So yeah, also a few years ago. And then for Longrich products
Wakata, Wakata.
specialist, I am so proud to say this. We were the first class. We were the first class of this academy, and I am so proud that we managed to finish that. So we are waiting as a class of 2021. We are waiting for class of 2022. We are looking at you. So you need to follow us. And I'm very proud to say I'm a Longrich product specialist under the leadership of PS Pulane.
Why is it cutting? There's something wrong with the network, eh? There's something wrong.
She doesn't take anything less than what she is expecting out of you. So you need to be there, then, and you will make it. And I'm very proud somebody. No, I'm not sure. I'm not sure today what is happening.
Yeah, you as soon as you started to talk about being a product specialist, yeah, cat, it just went from bad to worse. I don't know what happened.
Leadership. I can hear.
Really?
I can hear.
Okay. Okay. So, all right, you did your radiography core University of Pretoria. That one you heard. You did your mammography in Cape Town. Okay,
Yes.
and then go on, and then cut after that.
Oh, you were cut off after that. I'm sorry
After
about that.
that.
And then my product specialist, Longrich product specialist, I did it in the academy under the leadership of PS Pulane. And then I'm also a Longrich product stockist,
Okay.
where right now I'm based in Thohoyandou.
Toyando is where in Venda.
Limpopo Venda, yes.
Limpopo, which is South Africa.
Aha, it's still in South Africa.
Yes. No, we just have to make sure, in case, because not everyone is familiar with Toyando, not everyone is, geographically inclined. So we need to make sure.
Okay. No,
We need to make sure. Welcome, great leaders. So we are here with our newly qualified product specialist, PS Refilwe, who actually was number one of class 2022. She was the top two. She was number one of the class. So you got the best of the best here, the creme de la creme. So yeah, in the Health Hub, we bring you the best. So we really try to really give you the best content from specialists. Welcome, great leaders, Leader Lillian, Prof. Mankolo, welcome, Leader Gladys, Leader Olisa, welcome, great leaders. So at least we've got your background that you are ready. Some of us, I'll be like, what radiographer, what is that? So also Refilwe, just tell us, what do you do as a radiographer and mammographer? Welcome, Tina. What do you do as a radiographer and mammographer? What is it? What is that?
Okay, I'll try to be as simple as I can. Basically,
Simple.
radiography, we take X-rays. So X-rays, it's like rays that you cannot see. Remember in maths, we used to solve for X. So it's unknown rays. We don't know them. We can't see them. Yes, we do
With the
that
naked
so
eye.
that we can see mostly, yes, mostly we can see the bones, but you can also see the soft tissue. So with mammography, basically, it's going to be X-rays specifically of the breast.
Oh, okay. So there's sections to this
Breast.
thing. You know, some of us we don't know this thing
Yeah.
like this. Some of us we don't know these things. We just know A, B, C, D, and we don't know that after there's so many other things. So Osfifi, can you kindly share your presentation with us, Osfifi, with no further ado? Let's not keep our esteemed leaders waiting.
Okay, can you please help me with that one of sharing the screen? Then I'll put in the presentation leadership.
Hey, I tell you gotta press present.
Yes.
Hey, I tell you present, and then it's gonna give you like how we did yesterday when we did the sound check. It was yesterday in A. Present, and then that option in full screen, you tap into that screen where it gives you the option to share. Okay, perfect. Done. I'm adding it to the stream. Perfect. I'm so hopeful. I'm so proud of you. Why is this thing not adding? Okay,
Okay.
Eddie, but why is it not showing? Let me say remove. Let me add again. Now it's my.
It is
I'm the
there on
problem.
time.
Is it showing on your side? Because on my side it's not showing at all.
Yeah, it does show, but we need to put the presentation on.
Yes, okay, here, there it is. Okay, so I
Okay.
think maybe I made my side or your side, I don't know. But it's showing corner and you can share your screen leadership, your presentation. So while you're sharing the presentation, for leaders that do not know, how we normally do the trainings is that we train you and then please write your questions as we are training you and we will give you the floor to ask the questions after we do the training. So try not to ask your questions within the training so that we can concentrate. If you want to ask, feel free to do that. I'll just note them down. But for ease of reference, we normally ask you to save your questions for later after. Yeah, but so that we are on par. So please save your questions for later. You can ask your questions
Okay.
about breast cancer or any kind of cancer after the training though. Yeah, how do you feel it?
All right, leadership. Can you see my screen?
Perfect.
All right. Thank you, everyone. Let me try to put it on a slideshow. Okay. Thank you very much for being given
Yeah.
this opportunity to come and present to you about the breast cancer. I'll try to simplify some of the things because this is some of the presentations that we usually I was using at work because we need to present to the colleagues so that we alert each other about this. Even if we know about it, we still need to present as the requirement of the body that is governing the radiographers and mammographers, which is HPCSA. So my name is Refilwe Sekwaila, radio Longrich product specialist. I am with Leadership Pulane. Breast tissue, most commonly from the inner lining of milk ducts or the lobules that supply the ducts with milk, is the most common cancer in women and the second most common cause of cancer death in women in the world. 99% of breast cancers are found in females and 1% in males. Please note 99% of breast cancers are found in females and 1% in males. So I'm going to say a little bit about the male breast cancer because most of our males don't believe or don't take it in consideration that they can also have a cancer on their breast because they do have breast even if it's small, but breast cells are still there. It's a relatively rare cancer in men that originate from the breast. Chronic alcoholism has been linked to male breast cancer. The highest risk of male breast cancer is carried by men with Klinefelter syndrome. What is that? It's a condition used to describe males who have an extra X chromosome, which is going to give them the XXY because normally men have XY chromosome in most of their cells. So if the male is going to have XXY, it means that an extra chromosome is added. So yeah, they've got more features of a female on their breast. The relative risk of breast cancer to a female with an affected brother is approximately 30% higher than to a male with an affected sister. So I hope you get that. If a male has a breast cancer, it means the sisters or the females in the family, they are 30% more higher than having a breast cancer than the other females because it's very rare in males. So the tumor can occur over a wide age range, but typically appears in men in their 60s and 70s. So though even here they are saying 60s and 70s, we still advise people to check on themselves, especially above 40. Known risk factors include radiation exposure, exposure to female hormones, which is estrogen, and genetic factors. So in men, it's spread via lymphatics and bloodstream like in females. High estrogen exposure may occur by medication, obesity, or liver disease, and genetic links include a high prevalence of female breast cancer in close relatives. So here I'm going to be doing breast anatomy just to show a little bit how the breast look like and the inner part of it. So embryologically belong to integument. Functionally, part of reproductive system. I'm talking about the breast. And then respond to sexual stimulation. Also, it feeds the babies, that is the breast. And then our position is on the lateral aspect of the pectoral region, like it's on the side. And then location is between rib number 3 and rib number 6 or 7. So that is the location of the breast. And then it also extends from like sternum to the axilla, which is going to the outside. And then it's surrounded by superficial fascia and also rest on the deep fascias. So some of this I'm going to show you on the images that I'll be having on the next slides. So over here, we are having 4, and then the nipple is going to be our center. And then on the side there, we call that the tail of the breast. And then we're going to have the upper outer quadrant. It's on the outside. And then the lower outer quadrant also, it's on the outside but lower. So this is the lower inner quad and the upper inner quad. So those ones you will see on the following slides. Why do we need to know those quads of the breast? And then over here, we've got anatomy of the breast. So this is how our breasts look like. We've got ligaments, we've got fat, we've got lobules, and then our nipple is over there. This is the lateral side, like when they are cutting surgically. And then this is from the side, front side. This is how the breast will look like. Left breast is usually slightly larger. All. So because we've got the left and the right. If you stand in front of the mirror, normally you will see that your left breast is slightly larger than the right breast. And then the base of the breast is circular, either flattened or concave. And then it's separated from the pectoralis major muscles by fascia and rectomammary space. This is the anatomy of the breast, what I'm talking about. And then the structure, the outer surface is convex, skin covered. We've got a nipple situated on the fourth intercostal space. Intercostal is between the ribs. Then it's a small conical or cylindrical. Prominence below center, surrounded by areola. The areola is that the black pigmented area around the nipple. That's what we call the areola. And then areola contains the dark pigment that intensifies with pregnancy. In ladies, when you are pregnant, it becomes like more dark. That is the areola. It's circular and radial smooth muscle fibers. It causes the nipple to erect. That is the areola. For the nipple to erect is the muscles from the areola. So over here, this is our areola, and then this is our nipple. So we've got the opening, which is the duct opening where the milk usually comes from. It's a lot of them. And then over there, we've got those smaller glands. And then for lymphatics, clinically significant, glandular lymphatics drain into anterior axillary nodes, the central axillary nodes, apical nodes, deep cervical nodes, subclavicular nodes, and then to the medial quads drain into parasternal nodes. This is just that direction on how the lymph is draining in your breast. So yeah, we've got different nodes I'm gonna show you later on, and then this is just the way it drains. Superficial regions of skin, areola, nipple, they form channels and drain into pectoral nodes, and then axillary nodes also drain lymph from the arm. So those are the lymphs that I was talking about. These are the lymph nodes. And then over there, it will be where it is draining. So we've got the roots of metastasis, which means this is when the metastasis is going to take place. This is the route that it will be going through. And then from the medial lymphatics to parasternal nodes. Medial, it's inside, and then sternum, it's over here. So we are talking about the ones that will be going over there. And then across the sternum in lymphatics to opposite side via cross mammary pathways. So there are other ones that are crossing from one side to the other side. And then the other ones will be draining from subdiagrammatic lymphatic nodes. And then it's a diaphragm, it's under there. So it's draining from the breast, and then it's going through the diaphragm into the abdomen. That is where it's going to be going to the liver, ovaries, and peritoneum. And yes, this ones, it's from one breast to the other breast, and then the drainage from here is going down to the abdomen, and then over here will be going up to the axillary and also to your arm, those ones. And these ones will be the very same one that might go to your brain when the metastasis is advanced. And then this is how your blood flows through your breast, your blood flow in your breast. And then this is on the other view. And then over here, I'm still showing you the lymphatic drainage. And then let's come to the signs and symptoms of breast cancer. Every person should know the signs and symptoms of breast cancer. Performing monthly breast self-examination, you will be able to identify any changes in your breast. So as a person, you must know your breast. Don't be ashamed or shy. Each and every time when you take a bath, just get out of your bath or your bathtub or your shower or whatever. Stand in front of the mirror naked, look at your breast. Then you will know your breast. For you to see the signs and symptoms, you need to know your normal breast first. If you don't know your normal breast, then you cannot know or realize if there's something wrong with your breast. So the following signs can be noticed. We have a change in how the breast or the nipple feels. So when you are standing in front of your mirror, you must be checking your breast. Then that feeling, you'll get used to it. You will know how your breast feels. You will know how your nipple feels. Once there's a change in that, then that's how you're gonna pick it up and say, no man, my breast here have changed. It was not like this. And then the nipple tenderness or a lump or thickening in or near the breast or under the arm, you will be able to feel it. Change in skin texture or enlargement of the skin of the breast. When you check the breast, when it changes, can be like orange peel. We know the orange peel, it's rough. So then when it's roughish, then you know there is a change in that. And then a lump in the breast. Leadership Pulane. My network, it's something else. I'm sorry about that. I hope I'm still on. Signs and symptoms of breast cancer continues. A change in breast or nipple appearance. So once your breast or the nipple changes, you will see because you know them. Any unexplained change in size or shape of the breast, the dimpling anywhere on the breast, when the breast like goes in, unexplained swelling of the breast, especially if on one side, unexplained shrinking of the breast, especially if on one side too. I'm trying to find out if I'm still on, but hopefully I'm on. Recent asymmetry of the breast, although it is common for women to have one breast that is slightly larger than the other one, like your other breast, it's going to be slightly larger than the other one. So you must also know and notice that. Nipple that tend slightly inward or inverted, then you'll see your nipple as if it is going inside. Once it shows like it is going inside and the other one, it's still straight like that, then automatically it should alert you there's something wrong with that nipple. So you need to get checked out. Skin of the breast, areola, or nipple that becomes scaly, red or swollen, or may have ridges or pitting resembling the skin of an orange. Like I said, the orange, the way it looks like, then it will be rafunyana. So, and then, yeah, it becomes also hard. Then you need to go and get checked up. Any nipple discharge, particularly bloody discharge, that is a no-no. You need to go and get checked. It is important that a milky discharge that is present when a woman is not breastfeeding should be checked by her doctor. If you are not breastfeeding, then you also need to be checked. And then over here, we are going to do BSC, which is a breast self-examination. Women who are more than 20 years of age should regularly examine their breast. Start early, then you detect it very early. This should be performed after menstrual period has ended at least a week. Why do we say we need to do a BSE after your cycle, your menstruation? It's because when you are menstruating, your breast enlarges, changes, they become bigger. So you need to allow them to go back to their normal size. So give them a week. After a week, then you can do your BSC. And then BSC, is it necessary? Yes, it's very necessary because that's where you will know your breast regularly and you'll be able to see if there is any changes. So self-examination of the breast is essential for early detection of breast lumps. If lumps are cancerous, then detection is early and hence there is a chance of high cure rate. Reporting to a doctor becomes necessary when a lump is suspected. The best part of BSC technique is that it involves no expenditure and has absolutely no side effects. It's actually free. It only needs your time leaders. Just give yourself that little time. 15 minutes tops is enough. Performing BSE involves the following steps. You stand with your shoulder straight and arms on the hips in front of the mirror. Stand in front of the mirror and then your arms on the hips. Check for usual size, the shape, and the color. The following changes should be observed. Dimpling or bulging of the breast, inverted nipple, redness, soreness, rash, or swelling. So those are the things that you are looking for. If you don't have any of them, you are still okay. Please do it again next month. Additionally, these changes should be checked for with the arms placed at the sides. Also, arms placed over your head, like that. It's over your head, and then you're gonna be checking this breast, and then you go again the side, checking this breast. The pectoral muscles or the anterior chest muscles are contracted in this position. If there is a tumor, it affects the ligaments and hence dimpling of the skin may appear. So if there's something, your skin will go a little bit inside. So over here, what we are having, that is the inverted nipple. The nipple is going inside. It means something is pulling this nipple inside. So you need to go checked. Let's go. Okay, check the nipple discharge by squeezing. You need to squeeze the nipple. The discharge could be milky yellow or bloody fluid. Sorry about that. Sorry about that. Yeah, my network today is not okay. Yes, my network is not good. Let me come back. Okay, I hope I'm back. I hope I'm back. The head. Check using first few fingers of the left hand. This is your left hand. You check with your left hand, and then you must feel the breast with fingers by moving systematically using circular motions. Using circular motions from the nipple to the outer margins. So this is your nipple in the center, circular, you go like that. Make sure that you touch all the areas and then you go slightly outside until to the side, far away. This is also your breast. You check there. Examine keeping the fingers flat and then increase pressure to the deeper tissue so that the deeper tissue can be felt. So over there, you increase pressure. Make sure that you're pressing it inside. And then you repeat the above steps for the left breast using your right hand. Areas to examine with care. The entire breast should be examined every month. Areas that need special attention while examining are the outer side, that is the outer side, and the armpit, going there and then going over here on your collarbone, your clavicle, and below the breast, under there. Then also the middle part itself and the nipple itself. So over here, I'm going to talk about the clinical evaluation of a breast lump, history, physical examination, differential diagnosis, investigation, treatment, and prognosis. Under history, we have personal data, chief complaint, when and how first noticed, pain, tenderness, change in size over time, and with menstruation. So these are the things that you'll be saying, because those also are the things that you have noticed or you are going through. If there's pain, if it is tender, you'll also be talking about that. And then important things to ask about: malesthesia, is it cyclic versus non-cyclic? Meaning cyclic breast pain is associated with your menstrual cycle and it's hormonal. Sometimes when you are on your menstrual period, you do get some pains on your breast. So that pain, it's not a problem because it's during a specific cycle. Then after that, it goes away. So it's a hormonal pain, so we don't have to worry about it. And then we also check the skin changes, the redness, the warmth, the tenderness. You also need to know, is this breast, the temperature, is it too warm or what? That you need to know all those things. Nipple invasion, going inside, it's being pulled inside by something else. So you need to know all those things. And then nipple discharge, is it clear, yellow, white, green? What is the color of your nipple discharge? Blood stained or dark? If it is bloody, you need to know, or is it which stained or is it dark? You need to know that. And then purulent discharge, which is pus, is it coming out? Galactorrhea, a spontaneous flow of milk from the breast, unassociated with childbirth or nursing. If you are not nursing or your child, then we don't expect to see your a discharge being milky-like. No. And then gynecomastia, development of male mammary glands. So those are the things that you'll be looking at. And then gynecolic history. And then we have past medical history. So we'll be having benign breast disease, breast cancer, radiation therapy, to breast or axilla. So this is sort of the planning, what they will be planning. And then we also have the past surgical history. And have you ever had breast biopsy, lumpectomy? Did they remove the lump from your breast? Or did you have mastectomy, removing the whole breast? Or have you done hysterectomy, removing your hysterectomy, removing your ovaries, and then oophorectomy also? We need to find out if any of this have ever happened to you. Then that is when they are taking your history. And another thing that is very important is your family history. Are you the first one in the family having the breast cancer, or there are people that are having breast cancer? It might be closer or far away. For an example, I am in a family where we have a breast cancer. That's another thing that motivated me to be a mammogram a person. So my grandmother was diagnosed with breast cancer, and she was old and she didn't believe in that. It's not painful. And what happened? We end up going through mastectomy. So the breast was taken off. And then also constitutional features over here. We're going to be checking all those: anorexia, weight loss, respiratory symptoms, and then also check if there's any bone pains. And physical examination, they need to do physical examinations. Those are like physically, they are checking your skin changes. Is there edema, deepening redness, retraction, ulceration? And they also check your nipple, the discharge, the crusting, ulceration, inversion. So those are the things that they will be checking on your breast. And then also if there's a prominent veins, sometimes those veins will be like seen, they will be like outside, literally will be seeing them. So they will be checking that. Palpable axillary subclavic lymph nodes over there, they will be like rounds. The node, those lymph nodes will be outside, like almost there. You will palpate them and feel them. So they are also going to be checking your, if there is any arm edema, like swelling of the arm, if there is. And then we're coming to the characteristics of a breast mass. Characteristics of a breast mass. So here we're going to be checking the size, the position, mobility, composition, and fixation to underlying tissue or the skin. So that mass in your breast, if there is a mass, they're going to check the size, the position, is it moving? And then composition, like how does it feel when you press it? Is it rubbery? Is it hard? Or is it fluctuant? And then fixation on your skin, is it moving like left to right, or is it just fixed, staying still there? And then over here, we are having differential diagnosis of a breast lump. So we've got fibrocystic disease, we've got cyst, we've got adenomas, we've got fibroadenomas, we've got fat necrosis, papilloma, and breast cancer. All of those, they are breast lumps. So each and every lump, it doesn't mean that is a breast cancer. So it might be one of those above. That is why it's very important they need to check them first. So our breast masses for characterizing the age, common lesion, and then we've got characteristics. Age from 15 years to 25 years. Mostly common, it's fibroadenoma. Usually it's fine, it's round, mobile, it's non-tender. From ages 25 to 50, we have cyst, fibrocystic changes, and then we've got cancer in that age range. And then above 50, cancer until proven otherwise. So for pregnancy and lactation, so sometimes we do have masses while you are pregnant or you are breastfeeding. So those will be under pregnancy and lactations, but still they need to check them and verify. So over here, differential diagnosis of nipple discharge: bloody, serous, green, brown, purulent, or milky. Those are the types of the discharges. When it's bloody, we are suspecting papilloma, and then it might be cancerous or the pageant disease or fibrocystic changes. When it's serum, pregnant, every discharge need to be checked thoroughly. Over here, we've got investigations. Under investigations, these are standard investigations. We've got mammography, we've got ultrasound, biopsy, MRI, cytology, imaging for metastasis. So findings after exams: it might be malignant or benign. Where it's malignant, then it is cancerous. Benign, it's non-cancerous. Different steps and procedures will be taken for either of the results that they found. For benign, these are the benign ones: fibrocystic disease, fibroadenoma, fat necrosis, and papilloma. Those are non-cancerous lumps. So benign breast conditions consist of fibrous and cystic changes in breast. It occurs mostly between 30 and 50 years of age. Clinical features is breast pain, swelling with focal areas of modularity or cyst, frequently bilateral, varies with menstrual cycle. So frequently bilateral, it means on both breasts. It can be on one. And if no dominant mass, observe to ensure no mass dominates. And then greater than or above 40 years, mammography every 3 years. You need to do mammograms every 3 years. Avoid the xanthine containing products, which is coffee, tea, chocolate, cola drinks, and nicotine. This coffee, we are not talking about Longrich coffee. For severe symptoms, danazol, so it's going to be 2 to 3 months, or tamoxifen. So these leaders, you don't need to dwell on them. What is important over there, it's where we need to do our mammography exams. I'll advise, go and do yours every year. Do it when you are less than 30, but above 40, let's do them every year. Most common benign breast tumor in women, it's under 30. Benign breast tumor under 30. So no malignant potential. Clinical features: they are smooth, rubbery, discrete, well circumscribed nodule, non-tender, mobile, hormonal dependent. Management: usually exercise to confirm diagnosis. So we just sort of biopsy, we cut it, and then they take it to the lab and then check if it is really benign or it's not. Sometimes they leave it and then it will just go away, or they can just take it out, like lumpectomy. Due to trauma, that is fat necrosis, due to trauma, although positive history in only 50%. So clinical features: it's firm, ill-defined mass with skin or nipple retraction, and plus minus, it will be tenderness. Management of that will regress spontaneously, but complete excisional biopsy is the safest approach to rule out carcinoma. This one also, they are going to manage it by putting it that long needle for biopsy to get the tissue and then take it to the lab. And then for papilloma is solitary intraductal benign polyp, most common cause of bloody nipple discharge. Management excision of involved duct. So they're gonna go to the duct that it's having that, and then they will just take a little bit of the duct tissue and then take it for testing. Breast cancer malignant lump. Epidemiology, risk factors, pathology, staging, metastasis, treatment, local or regional recurrence, and prognosis. Now, this is what we are going through. Epidemiology, we are saying most common cancer is in women. And then it's a second leading cause of cancer mortality in women. Most common cancer of death is in 5th decade. Lifetime risk of 1 out of 9. Age 80% above 40. Gender 99% it's female. First degree relative with breast cancer. Risk increases if relative was pre-menopausal, before menopause. Then the risk is it's high because the person was still younger than what they are suspecting that breast cancer should start from this age to that age. And then nail parity, first pregnancy at late age. Nail parity, it's when you don't have kids. Risk factors continue, menarche, less than 12, menopause at more than 55. So you start your menstruation when you are less than 12 years, and then your menopause above 55 years. That is a risk factor. Obesity, excessive alcohol intake, high-fat diet, certain forms of fibrostic change, prior history of breast cancer, history of low-dose irradiation, prior breast biopsy, regardless of pathology, estrogen replacement may increase risk. So over here, it's those quadrants that I told you about. So 45% of the cancer, it's on the outer upper quadrant, 10% lower outer quadrant, then 5% over there, 15% is on this one. So this 1%, it's 1 centimeter around the areola. We are having 25% of the cancers there. And then we've got non-invasive ductal carcinoma in situ. It means it's still in the same position. Proliferation of malignant epithelial cell completely contained within the breast ducts. Risk of development of infiltrating ductal carcinoma in same breast is 25 to 30%. Considered a pre-malignant lesion. Non-invasive lobular carcinoma, proliferation of malignant epithelial cells completely contained within the breast lobe. This is the breast lobe. And then no palpable mass, no mammographic findings, usually found on biopsy for another abnormality. So it can be found when they are doing something else, not exactly that. These are the lobes over there. And then this one is the duct. This is the normal duct. Over there, we've got cells coming in, cells. Now this is closed. It's ductal carcinoma in situ over there. And then this one is invasive because now it is out of the duct. Now it's going away to the next station. It's no longer contained in the duct. It is moving. So the ones here is for the lobes, in the lobes. And then as we can see there, we still have something, but it is starting to block our lobe over there. And then ductal carcinoma, which is most common, 80%. It starts in the milk duct of the breast, breaks through the wall of the duct, and grows into the fatty tissue of the breast. It may spread to the other parts of the body through the lymphatic system and bloodstream. Patient's disease, which is 1 to 3%. So ductal carcinoma is the one that is the most common one that we have in the breast. Invades the nipple, ductal carcinoma that invades the nipple with scaling eczematoid lesion. So invasive lobal carcinoma, lobes, this one is the lobes, it's 8 to 10%. Originate from the lobes epithelium and spread to the other parts of the body, and it does not form microcalcifications. This one you cannot identify it very quickly. We've got inflammatory carcinoma, is a breast cancer caused by the cancer cells blocking lymph vessels in the skin. Most aggressive form of breast cancer, there is no lump or tumor. It makes the skin look red, feel warm, the breast skin is thickened, and then the skin looks like an apple peel. The affected breast becomes large, firm, tender, and itchy. It may be mistaken for mastitis, which is the breast infection. It tends to have more chances of spreading. So over here, we've got the angiosarcoma. It is very rare and usually develops as a complication of the previous radiation treatment. So this person was diagnosed with breast cancer, and then the person has mastectomy, and then the person went through radiation therapy. Then through that radiation therapy, then another cancer was formed. Access tumor size, nodal involvement, and metastasis, and then tumor size by palpation, mammogram, nodal involvement by palpation, metastasis by physical exam, and then we do chest x-ray and a bone scan to check the staging of the cancer. And then pathological histology, axillary dissection should be performed for accurate staging and to reduce risk of axillary recurrence. Estrogen, progesterone receptor testing, presence or absence of estrogen and progesterone receptors. And then over here is just to show when they are saying the person is on stage 0, 1, 2, 3, or 4. And then on 0, the tumor is still intact, is still in the situation. So regional nodes, nothing, metastasis, nothing. Stage 1, the tumor, it's less than 2 centimeters, and then no nodes, no metastasis. It's still in situation. Stage 2, the tumor is less than 2 centimeters or 2 to 5 centimeters or even more than 5 centimeters. Now it's movable. Now it is movable, ipsilateral, but it has not yet metastasis. And then stage 3, it can be any size. It is fixed, no metastasis yet. For stage 4, it is any size, any under-regional nodes. Now is distant, meaning it is like spreading to the other parts of the body. And I think I've shown how it spreads. It spread in 3 ways, going down to the abdomen, to the other breast, and up there. So primary treatment of breast cancer is a total mastectomy, which is they remove the breast tissue, the nipple areola complex, and the skin. And then we also have modified radical mastectomy, where they remove the breast tissue, the pectoral fascia, nipple areola complex, skin, and axillary lymph nodes. So over here, we've got the total mastectomy. The breast is removed. And then now we are coming to the treatment. That is the ductal total ipsilateral mastectomy versus wide local excision plus radiation therapy. So that is for the 1 year, the ducts. carcinoma. And then axillary node dissection is not required for the ducts. And then the cancer of the lobes, it's close observation versus bilateral total mastectomy, axillary node dissection, not required. And then Patient's disease, we're gonna be having a total mastectomy versus MRM, sorry. And then treatment for our stage 1 and stage 2. So we are going for surgery to cure stage 1 and 2. So on this one, there might be chemotherapy that the person is going through. It will depend on how far or what was the stage of the cancer. So treatment depends on the stage that you are on. We don't treat like everybody needs to go through this treatment. And then treatment, yeah, stage 3 and 4, operate for local control. It can include surgery, radiation, and systematic therapy individualized. But mastectomy is the most common procedure. Even with aggressive therapy, most patients die as a result of distant metastasis. Indication of chemotherapy: tumors more than 5 centimeters, inflammatory carcinomas, chest wall, or skin extension. So for stage 3 and 4, treatment will be different from stage 2 and 1. So stage 3 and 4 continues. Adjuvant therapy is a combination of chemotherapy. And then we've got indications where the node-positive patients, high-risk node-negative patient, and palliation for metastatic diseases. So they'll be putting these people like in different groups. So each and every one will be having their own treatment. Also, we've got a hormonal treatment, and then over there we'll be having tamoxifen, which is anti-estrogen agent of choice. And then we continue this for 5 years. And then also we're going to have radiation with breast conserving surgery, those with high risk of local recurrence. Adjuvant radiation to breast decreases local recurrence, increased disease-free survival, no change in overall survival. So on these stages, chances of a patient passing away is too high. Like if there is a lot of metastasis, then we are just going to be managing the pain. And then over here, we are coming for post-surgical management, follow-up of post-mastectomy patient. If you go for mastectomy, then you need to still go back for your checkups. That is very important. History and physically, every 4 to 6 months, yearly mammogram of remaining breast. So 4 to 6 months yearly, you must go for your mammograms. And then follow-ups of segmental mastectomy patients. Segment, something it was taken out, not the whole of it. Then it's still 4 to 6 months mammograms over 6 months for the first 2 years. Then after, it will go for mammograms every year. So our post-surgical management, we need chest x-ray to check if there's any metastasis, bone scan, and then liver functioning test, CT of abdomen, CT of brain. We are checking if there's any metastasis that has gone to the brain, how far to the abdomen, its livers to the liver, and then we're checking how far is that. And then over here, we've got recommended Longrich products, which we've got our green tea, we've got our cordyceps, we've got our berry oil, and then we've got our Arthro Sub Revive, and then over here is our doctor, which is the pie cup. So this pie cup, I believe each and every one of us has a pie cup because we need PICAP more than any other. We need PICAP for almost everything. We need PICAP. So in conclusion, leaders, it is very important to give ourselves 15 to 20 minutes every month to do our breast self-examination. In that 15 to 20 minutes, you can really save yourself. Cancer is not painful. By the time you feel pain, it has already spread. As it is said, it is a silent killer. And guys, leaders, beware of this silent killer, breast cancer. Thank you very much for your time. And yeah, it's not easy to be talking and then not sure if there's somebody who's there on the other side. Leadership Pulane.
Hi.
Hi.
Thank you so much. You are audible. You are perfect. Though network your house somewhere, yeah. But luckily you had slides prepared so we could make out what you were saying. You see how important it is to prepare.
My network is today it's worse. I don't know what is happening. I really don't know what is happening.
It's not as bad as last year. Remember last year when you did the training, you were nowhere.
No, I had to type. Yeah, I remember. I had to type because I couldn't.
Yeah. TSPP, you're born and you outdid yourself. The information was a bit scary. And we were talking about what? Naliparity. Hey, what's a higher grade? Medical English. Yeah,
No.
I even wrote it there. That all. If we say, tell us again, what is nulliparity? If you haven't given birth, you are high risk for cancer. Did I say right?
Yeah, if you don't have kids. Remember, another thing is when you don't have kids, you are also a very high risk of breast cancer.
Why is that? Okay, I know, but they need to educate us again. Why is that?
Remember on those slides that I was showing the breast, ne? The breast to have a nicely flowing blood flowing through your breast, you need something like you need to be sucked. Your breast need to be sucked. So yeah, I'm just gonna say it straight. Most of the breast cancers, ne, they are found by their spouses. Is the spouse that actually realizes that, hey, Muna, you've got a lump over here, because they will be touching the breast and stuff.
Most of the what?
Most of the lumps, the breast lumps, it's found by the spouse.
That is interesting.
For an example,
Yes.
Let me make an example with you. Your partner might be the one that found out that you've got a breast lump, because like we said, breast also is for sexual entertainment. So when you are touching, when he's touching you more breasting, obviously he's gonna know how your breast feels like more than when yourself. Then he will find, Rayman, there's something over here that it was not there all along. So it's very important.
So are you saying la? You know me again, but we're going to be professional about this.
Yes.
So you are basically saying men should do more touching and sucking.
Yes.
To save our lives. Our lives.
Yes.
That's what you're saying.
They must do more of the sucking, more of the. That's what
the specialist said it. The other specialist, not me. You heard it, ne? So our leaders, our male leaders, it is your duty as gentlemen. Do the gentleman-like thing and caress those breasts and suck those breasts, because why? You are saving your life. You are you are optimizing the circulation in that area.
Yes,
We need that
yes.
circulation.
There should be blood flow. It's when it's like when your
Yes.
breast is being touched, you have that feeling like you go like this. That is the feeling that you need so that your blood flows very nicely. So it shouldn't be like people should be ashamed
Taboo.
or something.
Yes.
No,
So
it
I was
was
saying that.
meant to be like that. So let's do it. It
Ah!
was meant
Did you hear
to
that?
be like that.
You heard that?
Let's do it.
Yes.
Yes. You suck it and you touch it. You are happy.
I'm sure the gents are very happy in here. Ah, in comes cargo. You comes in at the right time when we're talking about. Welcome to cargo. Hey, let's okay, moving on. So, all right. So you said, I think what nulliparity means women who have not given birth yet are high risk for
Yes.
breast cancer because
Yes.
as long as they didn't breastfeed, they did not nurse, and nursing
Yes.
is very
Yes.
healthy for the mother as well as the child.
Uh-huh.
But moreover, the men also need to do their part. The whole caressing and the playing.
Yes. Yes.
Foreplay,
Yes.
let's call it what it is,
So
foreplay.
so
This thing is two things.
even if when you have like maybe one child, ne, you
Mm,
still
mm.
at risk because the sucking is not enough. So
That's a mama.
the more you have kids, the more
Eh,
you are on a safer side. You are on a safer side, especially if you are breastfeeding. If you are not breastfeeding, you are just like all of us. So if you've got 4 kids, all have done the breastfeeding, then the sucking there is wonderful. And if
Some
you've got
two
one,
kids. The two I have are not enough. Is that what you're saying? I'd
it's
rather
not.
die come back and chicken.
No, it's not like there's a straight cut that you're gonna say 2 is not
Eh,
enough. But what I'm
mm,
saying is a woman who has 4 kids,
mm.
all of them has been breastfed. And the
Breastfed,
woman
okay.
who has 2 kids and they are also breastfed, you of
Mm.
2 kids, you have a higher risk
Of breast
than
cancer.
that one of 4. So the 4 better, the 2 you are. You see? So the male should do the sucking.
Yeah, no, because I'd
And
rather die and come back and chicken. So I'm not gonna make a third or fourth child. No way.
yeah,
Ah,
so
yeah, cut. Okay, so now the parity. Great leaders, please, you can ask questions. Now the floor is yours. While I'm asking PS Refilwe. Okay, so we got that out of the way. The importance of breastfeeding, right? Or
yes,
having your partner do, yeah, the touchy feely. We got that out
yes,
of the way. Now, on to Refilwe.
yes,
What's my other question, Nikana? So we are all at risk for breast cancer, right? It's not just
yes.
no, it's only the family. Then okay, so like for example, in my family, we don't have breast cancer, like
Mm-hmm.
at all. So does that mean that I'm still at risk?
Yes, you are still at risk. Why? Because you have breast. The risk
Leaders, if you
here,
hear
you have breast. If you
so
have breast, you are at risk. You
so my
might not
biological makeup is against me. Is that what you're saying?
come again, leadership.
Kira, my biological makeup is working against me. The fact that I've got boobs.
Yes, the fact that you've got boobs, you are at risk. So you
Leaders,
in your family, you might not have breast cancer, but you might be the first one in your family to have
to
breast
have it.
cancer. Meaning from you forward, your generation, then they'll be saying, in my family, we've got breast cancer while they are talking about you. So, like I said, me in my family, my grandmother had mastectomy. My sister had a lumpectomy. So they just removed the lump. So
Okay.
the only person who didn't have was my mother. So I am at risk. Me also am at risk because I have breast and because my family also it's breast cancer family. Yes.
And then I saw the other thing you also touched on is lifestyle. I saw that too much alcohol drinking is also one of the risk factors.
Yes.
Lifestyle.
So
so lifestyle
you are,
leaders.
it's lifestyle basically. It's just that they maybe mention alcohol. Basically, our lifestyle, the life that we are living, we need to try and practice living better. Then we'll be
Sorry.
able to avoid most of these things. Because remember, if maybe you are smoking, you are drinking, you are doing all those things, you are killing some of the things that needs to protect your body against certain things because of what is you are taking in. And then if you try to be more healthier, then you'll be actually being on the safer side. But nobody is safe, like I said. Nobody is safe. We just try to live a better lifestyle and then have our doctors with us all the time.
Yes, our doctor in the bottle.
Yes.
This is very interesting. And then what was my other question? Leaders, remember I said you can ask your questions, ne? You can ask your questions. The floor is now yours. Ask your questions on the breast cancer or cancer in general. I get it. This show is training, and we are here to what to educate and to empower. We need to know more about our products to know. By the way, also Philo, you said cancer is the what most prevalent cancer, ne? In females.
Come again?
You said cancer is the most prevalent cancer, ne? So the most diagnosed of all cancers. Did I hear you right?
I didn't get
You said breast cancer is the most diagnosed
leadership. You are
cancer.
cutting. I cannot hear you.
Serious, I can hear myself most. I don't know. I don't
In
know. I
women.
was saying, yes, breast
In
cancer is
women,
the
yes.
most,
Yes.
yes, in women. So we clearly have a business case. One good.
We do have a business
Do you
here,
know?
ma'am. We do have a business here.
We have a we have
Wow,
a
cut.
clear-cut business case. Yeah, I'm sorry. Maybe it's probably my network. I'm saying that we have a clear-cut business case.
Oh, yes, yes, we do. We do.
Yeah, because so you said what breast cancer is what the number two or is it the number one killer in women?
Number two.
What is the number one?
Now, number one, it was being said who is the cervical cancer.
So it's overtaken. Number two overtook number one.
Number one, it was said to be cervical cancer. So
Okay.
it's
And
also
it's got
it's unfortunate also because cervical cancer, Leona, it's still in
preventable.
us. So and there's no way that you're gonna say that you are safe, but with the products that you have recommended, we still gonna you have to take them, and just to be on a safe side, you just have to take them because
So leadership, as let's say I'm Mina and I want to take preventative measures. I get prevention is better than cure.
yes.
As a preventative measure, I'm saying I don't have cancer. As a preventative measure, what two or maybe three products should I be taking or using from Longrich on a daily basis?
The products that we just mentioned there, like we've got Arthro, isn't it? So
Yep.
what I love about Arthro, in a ginger, we've got ginger extracts in there. And then ginger is an effective treatment for nausea and vomiting. This one, it will help those that are already going through radiation therapy, because sometimes maybe they will feel like vomiting, liver chemo after injection, they will feel like vomiting. So that will help them. And then it also has it's anti-inflammatory, and it also fight infections. So any infection while they are treating or whatever, then it will be helping you. This one, definitely you're gonna need to take it when you are already diagnosed, because it will help you with those nausea and whatever
And the
feelings.
body pain.
And then
And the body pain.
we also have a berry oil. Berry oil, I will say, let's take berry oil whether you are diagnosed or not, because
Amen.
it has so many nice ingredients. We've got mega fatty acid, like 7. No? The 7, it says it promotes skin hydration. So remember the slide that I have shown you with the lady that was going through radiation and then developed the cancer on top
Yeah.
of that. Like, yes, that skin already, it's dead skin. And then over here, it says skin hydration, elasticity, and cell regeneration. That is berry oil. So it means it's going to help. And then it also has anti-inflammatory properties that help reduce swelling and redness associated with many skin conditions. So if you've got swelling, and then it's going to help you. The redness, where we were saying you can check if your breast is red or whatever. So before that, if you are taking berry oil, that is going to help you with that. And then we've got our pie cup. Pie cup, we've got 8 stones in it. So on this one, I'm going to mention the nano silver powder, and then which is anti-inflammatory, and then Callion. It helps manage signs on inflammation, relieve soreness, swelling inside the mouth caused by radiation. Also, this one is good on the person that is already going through radiation therapy, because if
Okay.
maybe there's those sores in the mouth and stuff, then this pie cup is going to help. And then we've got the Muyu stones that helps prevent against cancer. It's during your treatment or even before you are diagnosed with cancer, you can use your pie cup. So that is why we are always saying the pie cup is our doctor. So you need
Yeah.
that. And then for infrared stone relieves inflammatory. My Fanshi stone relieves pain and anti-inflammatory. We also are in pain during all these procedures. So to relieve pain, you also need that. And then the last one that I also like is Zyolite, which it alkalizes your body. So remember another thing maybe that I miss, cancer loves where there's more acid. So when you use the pie cup, which is going to make your body more alkaline, you will also be reducing the cells of cancer. You'll be reducing them because they don't have food. So they love where there's acid. But if you reduce that, it's going to help you. And then we've got green tea, where green tea is also had the anti-carcinogenic properties. So for the green tea, and it also reduces inflammation. And then cordyceps, they are potent anti-inflammatories. So all these products, all of them, inflammation, it reduces, and then they also deal with your cancers already if you are there, and then if you are going through radiation, it's also going to help you with your nausea. So for you who has not yet been diagnosed, keep on your berry oil, your pie cup, green tea, and cordyceps. Maybe you can leave out arthro, but leaving out still, you're gonna need it for something else.
Yeah, that's true. Wow, thank you so much. Thank you so much, our peers. Thank you so much. And then I tell you, me now, like that, I love to throw that out because that gives perspective. I guess.
I lost you, leadership. I lost
Oh,
you.
I'm confused. I was saying, giving out stats about anything. Like now we're talking about breast cancer. Giving
Okay.
out stats gives perspective. I guess.
Mm.
We need to understand why there is a whole month dedicated to breast cancer. I get October is breast cancer month.
Yes.
I get, and it's a global movement. It's not just for South Africa. It's a global movement. It's breast cancer awareness month, the whole of October. So we need to understand why, how come it came to be. All right. So first thing that I took from you is that as long as you have a breast, you are high risk or you are at risk. Let's put it that way.
Yes.
So males and females have breasts. I guess out of the way. If you did not give birth and become a nursing mother or breastfeed your kids, you are also at risk. And you are saying the more kids you have, the lower your chances of risk. Which, yeah, no. Now I still say my two kids are enough. I still say I'd rather die, come back a chicken. Yeah, no. That total is a miracle. I equal it. I'm not gonna make more than two kids. Never.
Uh,
So number two, you need to breastfeed the kids. And then number three is lifestyle. So lifestyle, you spoke about excessive alcohol. You also spoke about obesity as well. You also spoke about history. If ever there's also history in your family, you are high risk. But it's not only about high risk. I tell you, you cannot have history in the family and become the first one to have breast cancer in the family.
yes, you can be the first one.
You can be the first one. So now that I've sort of kind of summarized, leaders, please take note that in 2020 alone, 2.3 million women were diagnosed with breast cancer. In 2020 alone, 2.3 million women were diagnosed, new diagnosis. And then of the 2.3 million women, 685,000 of those women died from breast cancer globally. And as of end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years. These are our customers, are they not?
Exactly.
7.8 million. So obviously this is 2020 figures. So it can be more. It can now be over 8 million women who were diagnosed with breast cancer in the past 5 years who are our customers. Do we not have a business case? We actually have a business luggage. Now leaders like to say business case, not get a business luggage because wow, it's jam packed. You put in breast cancer, we've got products. You put in any kind of cancer, we've got products. You put in sugar diabetes, you put in hypertension, you put in all the leading lifestyle diseases. Longrich has the product. We've got a business luggage, not even a business case. So, P.S. Refilwe, thank you so much for your time and leadership. I see it's now gone after 8:30. It's now time for the Product Specialist Academy. I'm going to another training now. Now I'm doing the training. Thank you so much, my leader. Let's just give it another minute. Leaders, do you have any questions regarding breast cancer or cancer in general for our specialists of all sorts? Could be specialists of all sorts. No, everybody, man. Uta Team Cargo. Okay. Oh yes, my leadership, we have a business cargo. I like that. That's a nice pun. That's actually a very nice part. You actually have a whole cargo. Excuse the pun, actually pun intended in this case. Leaders, are there any questions? It's now 2036, 2037. We end the training. Do you have any questions, great leaders? We do have a business case. Please drink your Longrich tea. Drink the green tea. It has, like P.S. Refilwe said, it has anti-carcinogenic properties. That means what? Anti-cancer in layman terms. All right. Drink the green tea. All right. Drink your tea daily, not when you feel like it or when you are sick. Daily, because we are high risk. Daily, we are facing things that we do not know of. For leaders that do not know, I always say that pollution is also a factor in us being ill, and we are bombarded with pollution every second of every day. Who can run away from pollution? Please show me that person. I am still waiting. Nobody can run away from pollution. No one can run away from so many other things. In the next couple of weeks, I will be talking about. Let me see. Uh, Woof, very late there. On the 21st of November, I'll be talking about World Antimicrobial Awareness Week, where I will actually be showing you the dangers that you face every millisecond of the day. I'm going to switch up that training. I'm going to make it a bit different than last year. I need to really educate each and every one of you and see the risk that you take by not taking the Longrich tea. I'm not going. I'm just talking about the tea, alkaline pickup. I'm not even going to the supplements. Just taking the Longrich tea, drinking water from the alkaline pickup. Bona, you can add 10, 20, 30, maybe even 50 years to your lifespan. So, great leaders, thank you so much. Thank you so much, Mr. Cargo. I like your pun. It was very interesting. Thank you so much, great leaders. It's now gone 2038. P.S. Refilwe, do you have any last words that you want to add, our leader? Any last words that you want to add?
What I want to say, people must not be ashamed. You need to know your body, especially your breast. Just stand in front of that mirror. I mean, in a month, we've got 31 days. Just pick one day. It might be the 15, the 20, whatever. But very, very seriously so. Stand in the mirror, in front of the mirror, check your breast, know yourself before somebody else can know you. Know yourself. Then you'll see there is a difference somewhere, and then something changed. Then you'll be able to take it further, because breast cancer, it's not painful. You don't feel pain. By the time you feel pain, it's too late. You might be on stage 3, stage 4. And as we have seen, those stages, most people, they don't recover. They die. So please, 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 that is what I'm asking from you. 15 to 20 minutes of your time once a month can save your life. Thank you very much.
Wow, thank you so much, our PS. Thank you so much, great leaders. Also, Refilwe, thank you so much, Clay. Thank you so much. You've really given us your time for free, no al. So leaders should actually be so happy that a whole specialist of sorts is here, educating us for free. Thank you so much, also Refilwe. Maybe next year you can train us on something else. Let's switch it up. I don't know. I'm like that.
In October.
I don't know. Sometime next year. Not just October. There's January to December. Maybe you can train us on something else. I don't know. We will hear. And I'm like that though. Thank you so much, great leaders. Yes. Thank you so much. Thank you so much, great leaders. And we really have to thank P.S. Refilwe, a whole radiographer, mammographer, a whole long stockist and product specialist for actually giving us her time. That's the most important thing that anybody can give you right now. Time. Listen for free. Thank you so much. Thank you so much, my darling. We will connect offline, you know?
All right. Thank you. Bye.
Bye. So, great leaders, you heard it from the great specialist of thought. and look after yourself 15 to 20 minutes every month. Do the examinations. You can save your life. All right, Jen, do the right thing. You heard what the specialist said. I'm not going to repeat it. Just you can rewind and hear what the specialist said. Thank you so much, Great. We'll catch you next week, Monday. Adios.